Assalamu alaikum, everyone, and good afternoon. Welcome to the fifth bonus episode of the Do Health Systems Deliver series. I'm Dr. Khalid Al-Dosari, a health policy manager at the Center for Value and Health, and I would like to welcome you into this very special episode. And based on popular demand that we want to also to showcase more progress that we have in our healthcare system. So in today's session, we have a packed, dense, with very informative presentations and discussions for you guys. So I hope you enjoy. And as we have in the previous series, we have the Q&A boxes where you can type in your questions, and we'll try to answer them as the time allows for us for today, inshallah. So for this today's session, we wanted to showcase the feasibility study for the Council of Health Insurance to assess the market readiness for the implementation of patient-reported measures, which is linked to CHI's PROMs strategy, which was launched last year. So before we start, and without further ado, I would like to invite Dr. Sarah Al-Mnif, Director of Measurement at the Center, to give us a recap and highlight for today's session. Dr. Sarah, the floor is yours.
Thank you, Khalid, and thank you to CHI for their commitment towards PROMs and PROMs and advancing the space where we work, value-based care. I'm really excited to to be with you and host the last episode of our webinar series. We've been with you for the past few weeks now, discussing the implications of Paris and Do Health Systems Deliver? This session is a direct response to the really strong interest and feedback we received during previous episodes, particularly around practical implications and implementation of PROMs in the Saudi health system. The aim of this series has been to unpack the results of the OECD's Paris survey and really explore what they reveal about health system performance in Saudi Arabia. We've focused on understanding patient-reported outcomes and experiences as a tool to drive better and more equitable people-centered care. And now we'll unpack how that can be done. Again, in earlier sessions, we shared insights from PROMs and PROMs results, cross-country comparisons that highlighted areas where Saudi Arabia is aligned or not, the role of the provider sector and other care capabilities like digital infrastructure and team compositions and others. These discussions have really helped us shift the conversation from measurement for reporting to measurement for improvement. And today we take the next step from insights to implementation. We'll hear about the Council for Health Insurance's PROMs feasibility study, and how provider readiness was assessed, and what this means for providers going forward. We're also spotlighting providers who are already putting PROMs into action and looking ahead into the next phase of national implementation. So a quick recap about what we discussed during the past 4 episodes. So the OECD's Paris project focused on understanding patient-reported outcomes and experiences among those living with chronic disease mainly, since they're the leading cause of burden to the healthcare system, and understanding how these patients experience care is really critical for improving services design and delivery. 19 countries participated in Paris, and Saudi Arabia was one of them. And measuring outcomes and experiences of all adults attending primary care centers was the core goal of the project. The results showed that a striking 62% of respondents of adults reported living with one or more chronic disease. And as you see in the table, arthritis or chronic back or joint pain was the leading chronic condition, followed by diabetes and hypertension. So the table presents the percentage of patients who reported positive outcomes and experiences across the PROMs and PROMs domains that were measured, comparing those with and without chronic diseases in both age groups. A key takeaway is the consistent pattern of poor outcomes and experiences among individuals with chronic diseases, which really highlights the additional burden the group faces managing their care. Another striking finding was the very low rate of reported care coordination, which not only signals an area needing improvement, but really also highlights significant gaps for Saudi Arabia in the OECD's flagship report. Very interestingly, while mental health scores were relatively strong, it doesn't really translate to the overall scores of well-being, which does suggest that patients still are still struggling with the emotional weight of managing chronic diseases, which is something that requires a more holistic support model. So with that very brief overview, we've set the stage for today's really important discussion, shifting our focus from insights to implementation. We're honored to welcome our partners at CHI, whose leadership in advancing value-based care and patient-reported measures has really been instrumental in driving this agenda. CHI's PROMs feasibility study is really a milestone in our national journey towards value-based care and measurement. And we are extremely excited to learn more about the study's goals, methods, and findings today. So please join me in welcoming Mrs. Iman Al-Traghi along with the team from Prescani to walk us through the study and what it means for the future of care measurement in Saudi Arabia. Thank you.
Thank you so much, Dr. Sara, and we appreciate the great opportunity to be part of this wonderful series. I'll be today with you with my colleague Nasim Al-Mulla, the Director of Service Excellence from CHI, and also our great partners from HealthLinks, Prescani. We have Dr. Adil Al-Shaban, and we have Dr. Wasim, and the rest of the team from Prescani who will be, inshallah, joining us in this presentation. We will have also a special panel discussion at the end of the feasibility study where we invite pioneers from the private sector to share their experience and their journey implementing the PROMs. Again, thank you so much, and we hope, inshallah, we learn from this all together. So just to make sure that the slides are moving, if you can confirm, Dr. Sara. Great. Just quickly to remind myself, thank you so much, to remind myself and everyone that we were doing this as part of our Vision 2030 in building vibrant society. This is definitely done through the health sector transformation program, mainly focusing on the improvement of quality and efficiency of healthcare services. And this is the driver of considering value-based healthcare. CHI took the initiative to start working at early stage, starting from 2020 as part of the previous strategy, which has been completed last year, 2024, focusing on very important milestones and foundation to support the transition, and the journey definitely will continue. We remind also ourselves and everyone that no value-based healthcare without measuring outcomes. We definitely consider this framework where we put the patients at the center by focusing on outcomes that matters to patients. And this is the start of considering moving to measuring PROMs. The value equation is simply just by putting the outcomes, again, that matters to patients over costs that are associated with these outcomes or to deliver these outcomes. And our main focus is to is to enable the sector to measure the clinical outcomes, the PROMs, the clinical reported measures, also the patient experience reported measures, as well as the patient reported measures. And definitely, most of you have been working through the past few years, or maybe before, on the patient experience part, which we aim to definitely excel at, and also improve our experience at. But definitely it's considered quite mature compared to measuring the patient reported measures, or the PROMs, which is something that we can capitalize on to support this journey. So no value-based healthcare without patient-reported measures. This is the beginning of the kick for this work. CHI took a very promising journey, starting by measuring the PROMs. Maybe this has started from the private sector with a great effort from some of the pioneers who started implementing PROMs. Then in 2018, it became a national program supported by MOH. In 2023, we launched the CHI PROM strategy, where we defined the value-based healthcare, or defined the patient-reported measures, and also specify the priority conditions that we'll be focusing on. And in 2024, to support the implementation of the strategy, we have started the feasibility study, which is our focus in this session. The feasibility study aims to assess the readiness and the maturity of the market to adopt or to implement the CHI PROM strategy, and also understand the needs and the gaps that can delay the implementation, and how can we offer the support to the market. The national PROM strategy, or the CHI PROM strategy, and definitely most of the providers and other key stakeholders were part of it, focused on designing, integrating patient-reported measures into the care delivery, also developing the patient-reported measures integration, including patient classifications, data collection, and infrastructure and capabilities, and lastly, utilizing the insights and the information to support the improvement on patient level, also organization level, and also system level for population health monitoring. The work we have done, actually, it was done through multiple collaboration, including definitely our main partner, Press Ganey and HealthLinks. Then we realized the need also to engage other experts like Statista, ICHOM, and the PHO to support the stages of this project. We are so grateful that one of the outcomes of this study was the assessment to the maturity in implementing PROMs, which has been used in evaluating the submissions supporting CHI awards, specifically the track related to implementing CHI PROM strategy. And based on that, we were happy to announce 3 winners in our last ceremony. And we aim to definitely leverage on this and develop it to become more of a framework, or a maturity framework, to support the entire market. I will hand it to Dr. Adil to take us through the feasibility study, and I'll be happy to support. Abu Mariam, go ahead.
Thank you very much. It's a great honor to be part of this panel. I'm just going to give you an overview of what we're trying to do with this feasibility study. So when we started engaging with different providers, we wanted just to understand where do they stand today. So the first thing is just understand and get their feedback, whether they're on the provider side, whether they're on the payer side, the regulatory side, where do they stand on the measurement of patient-reported metrics. That was the first and main objective, because we didn't have the right grounds really to stand on in understanding where is the market today. We wanted also to check the digital readiness for engulfing PRMs into different data sets. Also, what our technology architecture is in place today, and what's the desired technology architecture to be in place to support the interoperability of the different measures that we have. And finally, there's a great move now in Saudi Arabia and the whole world toward better data governance, privacy, and security. I wanted to understand where do we stand here in Saudi Arabia compared to global practices, and identify those potential barriers for implementation. Now, it's very important that you see 4 of these 6 objectives are really digital readiness assessment based. Next, please. The desired outcome of all of this engagement is really, next, please. Yeah, desired outcome is really to integrate PROMs into care delivery, develop this architecture and infrastructure with capabilities, and leverage the real PRMs, the patient-reported measures, into empowering patients and organizations for benchmarking and value-based healthcare. So that's really the intent of this whole feasibility study. Next, please. How did we do the work? There was a long discovery activity phase. So we started, first of all, with stakeholder engagement. We had sessions through Presgani, we had sessions through iChom with the sector, 15 in total, focus groups, interviews, more than 50 participants, and we did engage all of the different stakeholder groups, whether they're regulators, payers, providers, or subject matter experts. Next, please. Then we did the market adoption assessment. So we wanted really to know where do people stand on PREMS measurement, how compliant they are in measuring PREMS, and how sophisticated they are in terms of measuring and reporting. We also wanted to understand the PROMs implementation in the different facilities, and Statista every year has its survey sent, and this year was no different, but we included CHI-based questions there to ensure that we do understand the implementation of PROMs in shade of the PRM strategy that CHI has. And finally, we did conduct a thorough digital readiness assessment for the sector. Now, the interesting part, when we were doing the study, I think midway during doing the study, we came with a novel idea. What if we integrate PREMS and PROMs into one tool? You know that we are measuring PREMS today in so many organizations in Saudi Arabia. Many of them have the granularity down to the physician level. So what would it take to integrate PROMs, given the national direction to measure PROMs, with the current PREMS tool and use that for population health? So we presented this to the steering committee and to the team at CHI, and we all agreed that it would not harm that we study this more in details. So we did conduct a limited pilot study to integrate PREMS and PROMs, 2 tools, EQ5D and PROMIS 10, into a single instrument with the current PREMS tool. Now, just to be mindful that these are generic PROMs tools, so we're not looking at disease-based surveying. We were just really trying to understand, is it doable from an operational point of view? What is the effect of adding the PROMs, generic PROMs tools to the PREMS tool? Is it valid? So that's a big question. If we integrate both, will it come up with a valid overall instrument? And with that, we will be able to advise the sector of the ability to integrate both PREMS and PROMs into one tool. Dr. Wasim will be sharing more details about this toward the end of the presentation, but I can give you a spoiler alert. It was a great success, and I think that it has a huge potential to be adopted in wider market. Now, it's important to mention that this has never, ever been done anywhere else. It's a novel for Saudi Arabia. We're very humbled and proud to be part of this movement. Now I'll hand it over to Dragana, who will take us through some of the findings of the feasibility study. So to you, Dragana.
Thank you and good afternoon all. It was my honor to be part of this feasibility study team that included our partners from HealthLinks and the CHI. As Adel pointed out, participants in all of the activities included hospitals, clinicians, industry experts, hospital executives. Upon completion of the interviews, our initial finding was that based on all the assessments and interviews, we have groups of stakeholders that engage around PROMs and promised value proposition differently. And we're best served to identify what the value proposition for each stakeholder group is at the beginning, so that we can engage those groups in the next steps and accelerate our learnings and their implementation strategies towards our desired goals. So, for example, some of the stakeholder groups included patients and clinicians at the top, hospital leaders and clinicians, payers, insurers, and hospital executives, but then also researchers, policymakers, and then all of the vendors and healthcare technology data partners that support this ecosystem. So for our patients and clinicians, we understand that they engage around patient-reported outcomes, around facilitating individual patient-centered discussions, to prioritize and treat and monitor diseases, and to monitor symptoms and health statuses. Our hospital leaders, they want to know and monitor and improve aggregate patient outcomes performance. And our insurers, of course, want to measure a relative cost and utilization, efficiencies, and to identify clinician level performance and best care pathways to promote and support going forward. Our researchers are our team that always engages or will engage around generating evidence that those care paths and best practices are yielding results and being and assisting in population health, optimization of the population health. And then our healthcare partners that will support data collection, data sharing, and analysis need to have the view of the infrastructure, a strong infrastructure, policies, privacy laws, and ensure that data quality and usability across that ecosystem is on par with all the data needs. So as a part of the feasibility study, we definitely had in mind and wanted to assess the current state, and this is what you see some of the findings of the current state are, and we wanted to do that so that we can see what the gap is to the optimal state. So for example, as we engage with our stakeholders, with our clinicians, our hospitals, and other stakeholders, we found that about 67% at that time, this was last year in March, of the stakeholders had already implemented or planned to implement patient-reported outcome instrument in their organizations. Those were somewhat of the non-standard instruments. It was based on their desire to measure and promote patient-reported outcomes in that organization. So standardization was lacking and is needed. 33% of facilities did not integrate PROMs into routine care delivery, while our 67% did integrate. So that was a great learning and a platform to go from and engage in implementation. The PROMs instrument, as I mentioned, were not validated or contextualized for the kingdom. And some of the examples included the language translations that was not validated. So we definitely wanted to assist Health Links and the CHI for the next steps around that. 33% of organizations plan to use PROMs, is defined outside of the scope of the CHI PROM strategy. So we really wanted to engage to assist them to align with the strategy. As I mentioned, we wanted to know what that gap is. So where are we now and where do we want to go so that you, CHI, Health Links, the ecosystem, knows what the lift is. What is the lift to the optimal state? And as you can see, the optimal state is this a state where all organizations demonstrate and integrate PROMs, patient-reported outcomes, into care delivery. The standards are aligned, they're aggregated. PROMs and PRAM in a PROM and PRAM survey. The survey instrument is contextualized and validated for the market. All organizations use PROMs for insights and to empower patient-reported patient care and to optimize performance. And then policies, it's all supported into policies and with policies and infrastructure. They exist and they're aligned for all the stakeholders with the CHI PRM strategy. So one of the learnings is that the largest gap, so to speak, is in a largest lift, I would say, is in digital readiness and preparedness. And those were the large areas we assessed. So feasibility study identified that to get to the optimal state, the highest level of lift and transformation is required by a regulator and the service providers, hospitals, insurances, clinicians in the area of patient-reported outcomes maturity, patient-reported tools, and digital transformation to get to the a state where the hospital system use the data for the purpose of improving patient care and care delivery. So we found that 33% of organizations that participated in the study plan to share PRM data. So it's 33% out of the total group. On the tools and the primary data, 50% of the feasibility study participants surveyed understand the PRM tools, but none of them plan to transform their electronic medical records for the CHI PROM strategy. The strategy was clear. However, the lift to transform the electronic medical system was great, and policies to do that were still needed. So the two steps that are really that would really cause or help this bridge this gap are to evaluate interoperability of all the existing and new tools, to publish the minimum data sets, and to allow multiple ways. This was a great finding, to allow multiple ways by which organizations can report and collect data. At first, we set on the electronic collection end-to-end system. However, this was a finding that in the meantime, we in CHI need to plan for this step of manual data reporting by some of the organizations. Secondly, as we put down our learnings from the study, we wanted to assist CHI in accelerating their implementation strategy by announcing this and letting them know what are the barriers that we find in the current ecosystem to the optimal implementation of the CHI PROM strategy. And the CHI took those barriers and already have proposed action and countermeasures that you see here. So some of the top barriers that we identified were the lack of standardization and measurement for PROM that allowed organizations that were more mature to go and do their own thing and select their own tools and do their own measurement. So the faster we can review and enhance qualification criteria and publish what that is, the faster we will get more mature organization on board and everybody else to look at the PROM strategy and identify that this is something they wanted to do. So the use of non-validated instrument was mentioned, lack of standardization for the clinical reported measures, and alignment of clinical reported measures or learning that we can have from a cross-functional data sets that include clinical reported measures is lacking, and then limited clinical and patient-reported outcomes data in the entire kingdom. So the lack of benchmarking, a lack of moving forward with the realization what care paths are optimal is still there. So adding that or overcoming that barrier sooner rather than later would allow implementation of the project with more mature providers, kind of having those goalposts for them to move forward with a standardized instrument with standardized CROM set would definitely be of great value. So we didn't only find the barriers, we found great things that support the CHI PROM strategy. And we found what the value is, what are the stakeholders finding a value, and why would they go and implement the CHI PROM strategy. So the values that our stakeholders engaged around when interviewed and discussing this with us in the focus groups was patient centricity, that now we're talking with the patient, with each patient, and we're realizing what their patient outcomes are and what their goals for their care path is. Value-based healthcare, we heard it over and over again, is an innovative program. We want to do it, but we want to retain autonomy. And then national benchmark, as we talked about, while lacking, this was an optimal and ultimate goal of all our stakeholders that discussed this with us. So some of the roadblocks that the interviews and focus groups identified is the lack of clarity about next steps. This would get the great value to our executives to plan for their digital transformation and what budgets are needed for those steps that are identifying some improvements that they need to do to their electronic medical records. Infrastructure and system changes are expensive. Standardization or requirements is lacking. And then there was a concern about fairness because so far there wasn't a great large data set that would allow everyone to know where they stand in that ecosystem of benchmarks. So to summarize, the key findings of the study around engagement of the stakeholders, which was one of our goals, were that organizations are familiar with the concepts of the CHI PROMs program and the EPRM framework. Organizations view this step as very positive and collaborative to moving forward to implementation. 67% of organizations already measure PROMs, so a great set of mature organizations are already there. They're looking forward to this new step in implementation. And then stakeholders desire great visibility into value-based healthcare roadmap and what is relative to CHI PROM strategy. As far as digital readiness assessment, which is our other goal of the study, we found that details around EPRM framework implementations were lacking, manual data collection was prevalent, limited electronic medical records capacity. There was limited capacity to exchange data electronically right now is desired, but we see this thing that exists only in the Saudi Arabia Unified National Healthcare Model for data exchange as a very solid foundation for this data interoperability and data exchange. And so as a part of the key findings and summarizing the study, the 4 steps to the implementation plan was that to measure market maturity and continue to measure market-wide maturity. We had a subset of the market that we discussed feasibility during the feasibility study, the steps of the CHI PROM strategy. So now market-wide maturity is in order measurement. Integrate PREMs and PROMs into standardized PRM data collection. And Adel, thank you, already announced some of the steps that were done there. Create a roadmap for market maturity. So how do we proceed? How do we know where we are in this implementation journey? And then create actions to identify the roadblocks and continue to identify these roadblocks and have actions to overcome them before they become an issue for the implementations. The actions that are already taken, you see them there, and then the next steps. Thank you, and I'll hand it over to Naseem next.
Thank you so much, Dragana. Naseem, you want to go through the framework quickly, the proposed framework to support the next step, inshallah?
Okay, good afternoon, everyone, and thank you for the opportunity to share what has been done in CHI. So, building on the feasibility study and the input that we received from the market and from the partners and the experts, and also from understanding the landscape of this work, we developed a framework to address and implement patient-reported measurements. And we divided it into 4 phases, and these phases come in sequence in order to, at the end, inform and support the value-based payment and value-based healthcare in general. So I'll just take you through it quickly. We will not go through details, but it starts first by developing the maturity of the market in terms of patient-reported measurement and support compliance through standardization of the tools, as well as developing expectations from the markets, and that could be done or leveraged through the accreditation and classification programs from CHI, and also by supporting the market through ICHOM or to gain ICHOM certification as an enablers. And also to continue doing that through the annual surveys, such as Statista, that supported us through understanding of the maturity of the market. So this is the first phase, which sets the tone and support the market through maturity. The second phase is by providing and working on standardized tools that are translated, that are contextualized. And this is something Dragana mentioned was a finding in the study, that we know that there are tools in the market that are being used. However, there are variations, no standardized tools. So this step will standardize what to measure and to work on what matters most to patients. So this is the first idea, and included also in this step, which is a very important component, is the primary data sets for the identified diseases. And currently we're working on the diseases that have been addressed in the CHI or National PROM strategy. And in order to expand this work into a much bigger scale, digital transformation is used and seen as a big enabler, since this includes working with importing data and sourcing the data, developing the right IT infrastructure, and sending this through a patient interface as well to reach the EPRM models. So this step, again, as it grows, is very crucial. And at the end, all of this information needs to feed into the value-based payment and value-based healthcare in order to reach efficiency, improve patient outcomes, and deliver high-quality care.
Thank you so much, Naseem. And definitely, in order to implement this, we'll be, inshallah, collaborating with the sector to create working groups for each track in order, inshallah, to implement it. A lot of co-design work will be done in the very near future. I'll hand it to you, Abu Mariam or Dr. Wasim, to take us through the pilot study quickly. I think we're running out of time, and we want to hear from our pioneers. Dr. Wasim?
No problem. Thank you very much. I'm just, like I said, in the interest of time, go through the pilot study rather quickly. In terms of the rationale and importance of the pilot study, I think it cannot be stressed enough that patient-reported experience measures and outcome measures are very important for reporting, the measuring for improvement culture. And as we mentioned in the webinar earlier, there are no existing tools within Saudi Arabia that actually integrate the full PREM survey and the PROM survey, and so to give us a holistic understanding. So that kind of is the reason for initiating the initial pilot study. The study itself had 3 objectives. What would happen if we combine the PREMs and the PROM survey? Would it be a valid instrument? The second one was to evaluate the response rates. Obviously, when you combine 2 instruments, the length and complexity of the survey can increase. What is the impact that this can have on patient participation? And lastly, we wanted to compare 2 very commonly used generic PROMs instruments, the PROMIS 10 and the EQ5D, and how they react to different measures within Saudi Arabia. How we did this, if you could move to the next slide, please. is essentially we conducted 450 surveys across 15 private healthcare facilities in Saudi Arabia. So the surveys themselves were conducted in 3 waves. The first wave was the PREM-only survey. The second wave was PREMS followed by EQ5D first, and then PROMIS 10. And the third wave was PREMS followed by PROMIS survey first and EQ5D second. This would allow us some iterations within the survey, which we can then use to study, one, the participation rates, and whether there's any difference, which of the PROM survey is used first or after. And this gives us an understanding of the complexity of the survey. The surveys were delivered via SMS, and both in English and Arabic languages to ensure inclusivity of the results. In terms of the analysis, if we can go next, please. In terms of the analysis, we wanted to understand 4 main things. So response rate, like I mentioned before, understanding if all the questions once added have any impact on patient participation. The second is the order effect. If we have the PROMs after the PREMs and the order of the PROM surveys themselves, would it make any impact on the instrument? Convergent validity essentially is measuring the correlation of the PROMs with an anchor question. In this case, we use symptom severity. Do PROMs instruments in this case have the discriminatory ability to identify if a patient has worse symptoms or no symptoms? And lastly, it's also important because we have a PREM survey, we wanted to understand the correlation of the PROMs with the PREMs, because again, this gives us that holistic understanding to, in terms of improvement. Now, the first results that we had in terms of response rates, obviously there's always a risk of lower completion. However, what we found within our surveys is that this response pattern is similar for EQ5D and for PROMIS 10. There were minimal drop rates, which actually, in a way signals that longer surveys, even though bring in complexity, patients are still willing to complete them. And essentially, they're still feasible to implement without compromising the engagement of patients. The next finding that we had is about combining PREMs and PROMs. Is it feasible? It is feasible and it is valuable. So 95% of the hospitals that we have within our PRESS-KNE database already use a PREM survey. So adding the PROM survey was actually quite well received in the pilot, and the order effect itself had no impact on how the patients completed the survey. We tried the PROMIS first and we tried the EQ5D first. However, there was no differences in the way it was completed by patients. This actually signals to us that integrated surveys are effective in gathering patient and holistic patient feedback. The next finding was about validity, the convergent validity. Essentially, we wanted to see whether the instruments can reliably track patient-reported symptoms. And what we found is both the instruments were actually quite reliable at this. So patients who reported worse symptoms were actually giving us lower scores on the PROMs, which actually should be the case. The health outcomes should be worse for patients who report worse symptoms. And this was reflected in both the tools, EQ5D and the PROMIS 10. And the final finding that I want to discuss is the correlation between PREMs and the PROMs. We use 2 PREMs instruments here, the likelihood to recommend and the overall patient experience score. And again, both surveys were highly correlated. So higher outcomes generally mean higher patient experience, and lower outcomes generally mean lower patient experience. So what this gives us is an idea that if we do have an integrated holistic tool in Saudi Arabia, it will help us in gathering that holistic patient experience that will help improvement efforts within the country. I think we can stop here. If we want to go through the overview, this is just the summary of findings, essentially, it's saying the same things. Thank you.
Thank you so much, Dr. Wasim. And we're working closely with our colleagues from the Ministry of Health at the Patient Experience Center to see whether it's possible to utilize the outcomes in the current National Patient Experience Program. And definitely, you will be updated on any progress around this. We encourage you all to visit our knowledge web base or the knowledge base in our webpage to learn more about our publications. We're aiming, inshallah, to publish a white paper on the feasibility study. So you should expect this to come out, inshallah, very soon. I'll hand it here quickly to my colleague, Nasim Al-Mulla, to moderate the panel discussion.
Hello again, everyone. We're very happy to host today a couple of the pioneers who did the work on the ground. So we have Dr. Anas from Dr. Suleiman Faqih Jeddah, and we have Mr. Abdel Majid from Saudi German Health, and we have Dr. Ahmed from Dalla Hospital. What we want to do today in the next 12 minutes or so is to try and understand the practicalities, the most important insights, and the lessons learned to be shared with other colleagues from other organizations. So this is what I would like our panels to shed light on. So let's start from the right. We'll start with Saudi German, Mr. Abdel Majid. My question that will go through to the three panelists is, as you implemented PROMs, I would like you to share with us the most valuable insight or lessons learned about the implementation of PROMs in your organization. تفضل أستاذ عبد المجيد الهمام.
السلام عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله.
I'll give, for the sake of time, I'll give you a very quick kind of structured phase-wise implementation of PROMs in Saudi German. We started by co-designing these PROMs with all the related stakeholders in terms of the collection process, the follow-up process, and how we will measure these outcomes in the end. We started using generic PROMs for adults and pediatrics, just to measure the general quality of life of our patients. In due time and with maturity with the collection and analysis of this data, we moved to disease-specific PROMs, which in our case included cataract surgery, bariatric surgery, pediatric asthma, diabetes, and much, much more. And then with time and enough maturity, we also, this is our latest step, is that we moved to PROMs collection of population-based PROMs, basically. For example, we started with ER, ICU, maternity and childhood, and others. I guess the key takeaway from this is to follow this kind of natural progression in terms of implementation. We don't have to start directly with disease-specific on a provider level. We can start with generic, and with time and maturity of the process, we can move on to disease-specific and then maybe population-based PROMs. In the implementation phase, we started collecting this data manually. And as I said, in due time and with enough maturity, we developed this kind of hybrid system of data capturing, where we have a QR code ready for the patients to scan, and they can provide their PROMs answers by paper or or electronically, just for the convenience for the patients. And for us, in the end, we will have one final digital set of data that we can analyze and use to follow up with our patients. And our final step would be to follow up with the patients. So we do that with physicians follow up with these patients to kind of measure their quality of life, and then they would retake the PROMs. We would then we would analyze this data to see if there is any correlation in their health status, comparing the baseline and the follow-up visits. For example, in bariatric surgery, we noticed that patients' quality of life was increasing, but there was also a case of anxiety, which kind of helps us navigate that their care plan needs to involve some sort of mental health aspect into it. I'll hand it over to the rest of the colleagues. Thank you.
Thank you so much, Mr. Abdel Majid. What I noticed here is, first of all, you emphasized on co-design before you start to implement. And I liked your approach of how you phased out your implementation, starting from the generic PROMs into disease-specific. Also, the way you collected your data, you started simply, and then you phased out into more sophisticated way. And I really liked how you integrated this into patient care and into other clinical outcomes. So thank you so much. We'd love to hear more, hopefully on another platform. So I will move now to Dr. Anas, please. So the same question, the most valuable insight or lesson regarding your implementation experience.
Sure. Thank you, Dr. Nassim. Thanks to all the team and for the organization and for the invitation. the nice thing that we had the result of the feasibility study today firsthand, so fresh from you and the team. Thank you. We're learning a lot from you. I just want to to complete the circle of the most important lesson learned, as mentioned by Mr. Abdelmajid or Dr. Abdelmajid, that think big, act small, act fast. This is the approach that we need to carry in the value-based care strategy implementation. One or two of the most important things that helped us a lot to move toward more successful implementation or initial steps of implementation was the leadership support. So I think, and this is always one of the important words in any project. And to be honest, this was one of the major factors or pillars that gave us the opportunity to invest our time, resources to successfully do the right steps toward the implementation of PROMs measurement or value-based care strategy on the track. On the other hand, this created with the leadership support more multiple platform to create the culture or the change management approach where creating the urgency as a first step was easy. Today, I'm very proud of the leadership in the group where our CFO, our admin, our clinician, our nurse, they know and they speak the same language about value-based care. I was very happy to see our CFO sitting in one of the meetings and happy about the implementation of value-based care and mentioning and referring to the value-based care. And this is reflected from the leadership support, translated into a culture, supported by the infrastructure of the four pillars that mentioned by Mr. Adil before: technology and the data governance. This is one of the critical items as a data governance in the organization. It's helped us with our infrastructure to go with the multiple levels, including the analytics and the way of integration into the AMR in alignment with the three levels that was mentioned by Ms. Iman earlier in the presentation: the macro, the meso, the macro level. Because no point to gather the information and the physician is not sitting on the clinic discussing those information with the patient. I don't want to take all the time, and I want to give more opportunity to colleagues to comment. So in a summary, leadership, culture, and data governance and technology.
Thank you, Dr. Anas. And I would add from what I heard from you here that you also ensured that this work is aligned with the overall organizational strategy, and you addressed specifically value-based healthcare. And I really like the idea that you thought of change management and creating a sense of urgency to initiate this work. Finally, and I'm very happy to hear that you're addressing the usability of this data. So it's not just nice dashboards. You want to use it and to be translated at the point of care. This is very valuable. Thank you so much, Dr. Anas. Finally, want to hear from our colleagues in Dalla Hospital. Dr. Ahmed, tfaddal, if you want to also share the most valuable insight you want to share with our colleagues.
Thank you so much for having me, and thank you for this panel and the fellows attending this. Actually, I'm going to summarize all of those in 5 points. Okay, so first point, we should realize the fact that value-based healthcare as a concept does not address the issue of patient access. I'm saying this because actually Saudi Arabia can do better than the American system. I've been trained on value-based healthcare at Harvard by Michael Porter, the founder of this. But actually, Saudi Arabia can do better off than American system because the structure of the healthcare system in Saudi Arabia. So this is first, because the patient is assumed to have his or her own access to our system first, insured or not even. So the patient has the access, and then value-based healthcare can kick in. So I guess Saudi Arabia can integrate population health with the value-based healthcare to do better than the states here. This is the first point. Second point, we are talking about PROMs, and with my all due respect, but still there is a piece of puzzle here has to be integrated with this, which is CROMs, clinical reported outcome measures, to do the proper correlation between both. For example, if you have a maternity pathway for a pregnant lady, and then the clinical depression scale, for example, alerts us that there is a problem with the clinical depression scale here. It's scored high, and this is bad. Actually, if we correlate to the clinical data, sometimes those ladies has a history or actually under treatment of hypothyroidism, for example, okay, of lack of social support, another scale. So actually, when we are integrating the clinical reported outcome measures with the PROMs, patient-reported outcomes, and the PREMs, the patient-reported experience, all together will give us bigger and better picture for this patient. Plus, here, when it comes to the instruments we are using, actually, we send like a recommendation to ISHM actually to update, and they are updating now the instruments they are using, because sometimes the literature behind those surveys are very, like 70, 80 years back, okay? Plus contextualization to Saudi Arabia in terms of the Arabic translation to the Arabic population, and figuring out the slang, proper slang you are using, okay, because there are different slangs in different regions and different expatriates in different regions in Saudi Arabia. So contextualization here and validating this has to be taken in consideration. So third point, Naseem, تفضلي عفوا.
Yeah, I think we have like 4 minutes to end. So please, if you could summarize in less than 1 minute, thank you.
The big thing now, the data collection. So the patient we should be patient with them, because it is a lot of data collection, and then to incentivize our staff for data collection, and then the technology, okay, and a lot of details and devils lies here. Actually, the EHR integration with the data collection platform, patient experience platform, and even integrating biomedical devices, for example, optometry devices, to our system. Otherwise, it's going to be a hell to collect the data for value-based healthcare or PROMs project. Number 4, big data analytics for those we are talking about, and just I leave it like this because we should consider big statistical and data science projects here, and finally to do the liaison with the cost, and it's going to take time, so we should be patient. Thank you so much.
Thank you so much, Dr. Ahmed. Just to summarize, I really like how you addressed, the issue holistically, looking into access, into other projects of value-based healthcare, and how to integrate this into the whole cycle. Just in summary from our colleagues, it's very important to phase this work out because of its complexity. Co-design is a very good way. Moving from manual to hybrid into fully integrated system. Also, Dr. Anas addressed the importance of infrastructure and investing in an infrastructure that supports the culture and leadership engagement, and having this as a priority, strategic priority, I would say, for your organization would support this work. And finally, Dr. Ahmed, you really highlighted issues. So if patients are struggling with access, how would we even be able to measure their outcomes and experience? So thank you so much for our colleagues of highlighting these important lessons. And I'll hand it over to my colleague, Iman. تفضلي يا Iman.
Thank you so much, Naseem, and thank you for all the panelists. It's been a very valuable insights and experience to share. And it's been a great opportunity to present the feasibility study. We're happy to take any questions. I want to hand it to Dr. Sarah. Dr. Sarah, if you want to conclude.
Thank you. Before we conclude, there's just a couple of questions maybe we can take right now. Someone's asking in the chat why there wasn't any governmental or semi-governmental institutions included in the feasibility study.
So the work started focusing on the private sector. So this was the initial scope of the study. Definitely, one of the findings is, and we extended the exercise a bit, and then we realized that there are a lot of great steps in the public sector. We will be definitely considering this in the future, but it's always good to start small, as they say, and start small, fail cheap, as they say, and then we can definitely expand. But absolutely, for all initiatives and upcoming steps, we'll be including the entire sector, b'idhnillah.
Great. One more question. I think we can cover this. What was your approach to minimize survey fatigue and improve the response rate?
So
I think I can take this question.
Yeah, I will hand it to you, Abu Mariam. Oh, yeah, or Dr. Wasim, yes, go ahead.
Yeah, so because this was the first time we were running this pilot study, we actually wanted to study if there was any survey fatigue. Hence, there was no approach taken to minimize survey fatigue or improve response rate because, as I mentioned in the pilot study, one of the aims was to understand if we make the survey lengthier and more complex, does it actually affect patient participation and engagement? So these two were you could say, variables to study.
Great. So I think we're at time, which is a perfect timing for the last comment, Wasim. But thank you to all of our speakers today from the Council of Health Insurance, Press Ganey, and the provider organizations. Your insights were really valuable and contributions were highly accepted. A special thanks to our audience for joining us and actively engaging in the discussion today. During today's session, we took a step forward in our journey from feasibility to implementation. We heard how CHI effectively assessed provider readiness and system infrastructure. And we really saw promising examples of how the private sector are already putting PROMs into action. Key takeaways include CHI's leadership in evaluating readiness and building the foundation for PROMs integration, and real-world implementation stories from early adopters. And then at the end, we really have a shared national vision for scaling PROMs as a part of routine healthcare delivery. Now, the feasibility study has really laid the groundwork for informed policymakers and rollout of PROMs measurement. And now with the Paris results in hand, we have a timely opportunity to align on a national roadmap for PROMs adoption, anchored in data, collaboration, and patient-centeredness. At Value in Health, we remain committed to supporting this transition through either practical tools, capacity building, and alignment with national priorities. So as we move forward, let's really continue working together to create a healthcare system that listens to patients, measures what matters, and really delivers true value. Again, a tremendous thank you to our guest speakers from Faqih, Dalla, and Saudi German. And thank you to CHI for producing this valuable piece of work for the system. And thank you to our audience and attendees. A kind reminder to complete the feedback survey we will share after the webinar. This is going to help tailor future events and products. And thank you once again. We really look forward to welcoming you in future webinars as we continue this journey towards value-based care. Thank you, everyone, and have a great day.
Thank you, everyone.
Thank you so much. Bye-bye.
Thank you.
Thank you.